joining us today. It's Friday morning in Houston, early morning. So folks who don't know me, I'm Shubham Pant. I'm from Delhi, born, brought up in Delhi. Dad was in the army, went to Maulana Azad Medical College, and then, came to the US to do my residency and fellowship. And at the present time, I'm a professor of medical oncology at MD Anderson in Houston, in Texas. So my specialty basically is GI medical oncology, and I also do phase 1 drug development. So both, which is called early phase drug development, and that phase 1 has morphed over time. First we used to do most of phase 1s were just for safety and tolerability, but I'll show you some data in which we've done phase 1 studies, which were targeted therapies, which are basically targeted therapies in which we have seen responses in phase 1. So that's just a shot of Anderson, and this is that's who I am. So this is just a quick 10-minute talk. I have a longer, like an hour-long talk that I'm going to give soon. That I'll show you where I'm going to give it in India. I'm coming in June to India. But why is when we say KRAS, and I really, believe that we're going to have a RAS revolution coming in the next decade. Like I've seen more interest in KRAS in the last 3 years than I've seen in my, since 2008 when I graduated from fellowship. But on the first, why is KRAS undruggable? Why is it such a tough target? And the reason is they're twofold. There are quite a few reasons. There are two big fold reasons. One, KRAS, think about like a shiny ball. We can't stick anything to it. You don't have a little groove to stick anything to it. So any drug that you try to inhibit KRAS with, it kind of slides off the surface of the protein. So that's what makes it very tricky. The second thing is the KRAS it's essentially bound in the on state. So it's GTP, T as in, so that's the phosphorylation, GDP to GTP. That's how drugs are activated, right? That's how these targets are activated by the phosphorylation. So it's very highly bound, tightly bound in the GTP phase. So you can't disassociate the drug. So it's basically a signal which should be turned off, but it's turned on constitutively all the time. It's very hard to bind it in the GDP phase. And that's important because a lot of the drug development is either binding it in the on phase, which we thought never could happen, but now it's happening, or trying to bind it in the off state, GDP phase, so that it doesn't kind of, get activated essentially. So those are the two big things. So one, shiny ball, can't stick anything to it. The second thing is it's essentially in this very highly active GTP phase. And that, it's like, when I was growing up in India, we used to call it Fevicol ka bond, right? So that bond is very tight, essentially, in the GTP phase. So you can't really break it. That's important. Next slide. So this is kind of the overall history of KRAS. This is, it was 39 years from the discovery to the approval of the first KRAS drug. And what Bhavna just mentioned, Sotorasib, that was kind of one of the first ones which was approved. Next slide. So next slide, please. So I'm first going to talk about, today my talk, D is a longer talk. It's frankly more translational and basic science, some clinical. So D inhibitors are in the clinic right now, but it'll take about a year for all of them to kind of, come to where we can really see responses. Maybe not even a year, maybe 6 months, but still it's a little bit early. But, this is overall when you see, the overall landscape of KRAS mutations. Obviously, we know it's one of the highly mutated genes in cancer. So really, it's very important to target this mutation. And G12C is, kind of more expressed, as you can see, in lung cancer, 15%, colon cancer, a small number of patients with pancreatic cancer, 1.5%. We also have about 1.5% of patients with biliary tract cancers who have KRAS G12C mutation, and colorectal cancer is about 4%. So KRAS G12C is obviously was a good target for non-GI and for GI purposes. Next slide. So this was the first from 2013. So what the Shokat and colleagues, and he's been the front runner in targeting KRAS. What they figured out was that they found this little switch pocket. So it was this little pocket, which was called the switch 2 pocket of the GDP bound form of KRAS G12C. So they could kind of bind it to the inactive form. So as you see on the left, this cartoon, which I have, which says inactive GDP in the red and active GTP in the green. As you can see, you always have this exchange from GDP to GTP, and then you have hydrolysis of the phosphate. So you lose the phosphate, it becomes the inactive GDP. So when it's turned on, this hydrolysis is turned off. As you can see, this little line that you can see, this little dotted line. So remember I told you, it's always like on in the GTP phase. That's what happens. The hydrolysis goes off, so it's kind of bound in the GTP phase. But this thing can get into, they found this little pocket in G12C, which you can get into this GDP phase and bind it in that. So this was one of the first areas where, people said, hey, this RAS, which is called the undruggable, can be, it can be drugged, basically. Next slide. So I'm going to kind of focus today a little bit. You've probably there's people know a little bit about the lung data and the colorectal data just because those are kind of going towards approval. But I'll show you something that you might, not see that commonly is kind of the pancreatic data and the biliary tract cancer data. So Sotorasib, was the first one that we had done. And this was a trial that we ran in MD Anderson also. One of my colleagues in phase 1, David Hong, ran it, and I was one of the investigators with him. If you see, this is the Sotorasib in pancreatic cancer, which was 38 patients, again, small numbers, but again, it's 1.5%. The overall response rate was 21%. So whenever you see a waterfall plot, for the fellow and junior faculty over here, whenever you see a waterfall plot, remember, when they say response rate, overall response rate, that means you have a more than 30% reduction in size of the target lesions that we measure, right? But really, even if you have a 10% reduction with the CA 19.9 going down, that's very clinically significant to the patient with pancreatic cancer. So I always like to see the waterfall plots because it really tells me, how the drug is really working. And this seems to be that the drug is having an impact. So the response rate may be 20%, but the disease control rate, which is response rate plus stable disease, is much, much higher. So 20% response rate and about 4 months median progression-free survival. Remember, these are very refractory pancreatic cancer patients. Their median progression-free survival is probably a month at this stage, but they did, okay-ish with this drug. Next slide. So I'm going to talk about a little bit about Adagrasib, again, in patients who are non-colorectal, non-spell. So this is one of the trials that that I presented in ASCO last year that we published subsequently in JCO. And this was the Crystal one. So this was essentially, again, a phase 1 trial, but it was a basket cohort. So this was non-colorectal, non-lung. This was a basket cohort that we enrolled patients in. Next slide. And to Bhavna's point, about the Sotorasib that you said, maybe Adagrasib is better than Sotorasib. Again, you can't cross compare, obviously, but taking, because nobody's ever going to compare Soto to Ada. But I can tell you, Ada is a little different than Soto. Just because two are G12C inhibitors, that does not mean they're the same. We see this in drug development all the time. And I think we saw this in lung cancer, right? You had the early inhibitors of EGFR, and then you got better and better and better inhibitors. They maybe bound a little bit better. They were more selective targeting. So it happens in drug development all the time. And I'll show you some slides in which you'll see how the progression has really rapidly evolved. Earlier, it used to take us 2 decades to get to this point. Now, in 3 years, you have like one drug after the other because it becomes like an arms race almost amongst the drug companies, right? How do we get it? Where do we get it approved? So it's kind of a complicated, it's fairly complicated. However, the history of drug development, especially as we see with lung cancer with these molecules, is you start with an agent which inhibits it, and then you get better and better at formulating the agent, right? Target sensitivity, how it binds. So ADA is a little different. If you see, it has a long half-life first, about 23 hours. Sotorasib is about 4.5 to 5 hours. Okay, so that's a difference. They have something called dose-dependent pharmacokinetics. That means as your drug goes, it goes to, I'm just going to 100 milligrams, 200 milligrams, 400 milligrams, 800 milligrams. It's a linear pharmacokinetic. That means you can see the line kind of follow that increase, the exposure of the drug. Whereas Sotorasib has a non-linear pharmacokinetics. After a certain point, Sotorasib, we don't know how it kind of, so one of the criticisms of Sotorasib has been maybe that 920 milligrams is too high a dose. Maybe you can use a lower dose, which is probably a more biologically effective dose. So there are real differences. And it also, I think, binds a little bit better. So it is potentially, I mean, I'm a little biased. Obviously, I did studies with ADA, but keeping my biases aside, the data shows that probably the response rates is a little bit higher and a little bit more durable. But there are potentially better drugs than ADA coming also that I'll show you. So next slide. This was our study in which we used, everything except non-small cell and colorectal. Next slide. As you can see, we had 21 patients with pancreatic and 12 with biliary and 10 with appendiceal, because all these can have KRAS G12C. Interestingly, we also had 5 with ovarian that were part of the cohort. So kind of a very broad basket cohort. Next slide. So if you look at this is a waterfall plot. Looks a little bit better, right, than I showed you with Soto, but this is all patients. But I'll show you the pancreatic and the biliary next. Next slide. And can you hold that a little bit? So basically, if you see, look at that. Every patient in the PDAC had some kind of, not every, but I'm saying 80% of patients had some kind of shrinkage of tumor lesions, some kind of decrease. Look at the BTC, like every patient had some kind of shrinkage of the tumor lesions. So the confirmed overall response rate, remember it was 21% with Soto. Again, no cross comparisons, but if you really look at the confirmed overall response rate with ADA was 33% in PDAC patients. Disease control rate, stable disease plus response was 81%. BTC, again, 41%. So BTC RAS, RAS is not the same. The KRAS, which is in lung, is different than RAS than is in, even though they may be the same allele, is different than the RAS in colorectal, different in PDAC, different in BTC. Sometimes we've seen that, and I'm going into the weeds here, that you need maybe higher doses to inhibit the RAS or better binding for PDAC, because pancreatic cancer is a little bit tougher because that bond is a little bit stronger. So you might need a higher dosing of this of the drugs or better binding. But I wouldn't escalate the dosage just because I said that. I'm just saying this is more theoretical right now than practical application. But anyway, so as you can see, good responses in both biliary tract cancers and PDAC. Next slide. So this is the other GI cancer. So appendiceal did not have any response rates because they don't really respond, right? Appendiceal cancers, it's like the mucinous, stable disease, 1 to 2% here or there. When on scans, we don't see these dramatic reductions in size of tumor lesions, basically. So as you can see, appendiceal, but the disease control rate in appendiceal was 85%. So really controlled the disease, kept them under check for a long time. Interestingly, our ovarian cohort had like a 57%, 50% response rate. We had 3 patients, the endometrial, who had a 66% response rate. So highly, if you can find this mutation in endometrial and ovarian, they have a very good response rate actually with the G12C inhibitors. Next slide. So this is just the median progression-free survival and the overall survival. Remember, this is a PDAC of 8 months of median overall survival. I'm talking about patients who have gone through standard of care therapy. Majority of these patients had one, and majority had almost all of these patients, almost all had one. Majority had 2 lines of therapy, basically. So this is highly refractory PDAC patients. And you can see a median overall survival of like 8 months, which is like, our frontline regimen when we give like Gemabraxane or something to patients with PDAC. Next slide. This is just the overall survival of BTC. Again, the BTC median overall survival, again, these are pre-treated. These are not like first-line patients, 15 months, right? That's a good median overall survival for these patients. Next slide. So the treatment-related adverse events, mostly what I've seen that ADA is diarrhea. So you have to learn to control it, give antidiarrheals very early on. And you can actually, this dose was 600 BID. I think you can even treat them at 400 BID and have a very effective dose essentially of ADA. I've seen great responses. I've even gone to 200 BID and seen some patients continue their response essentially. Next slide. Next slide. This is just the conclusion. So where are we going next with this field, right? So I've shown you the now, but where are we going next with the field? So this is the Lilly G12C inhibitor. This was presented in AACR. AACR last year, was updated in ASCO GI last year. So this was a Lilly G12C inhibitor. Next slide. And then this is the response rate. So if you see the response rate in pancreatic, again, this is just 12 patients. Remember, I showed you higher cohorts with Sotorasib, more patients with Adagrasib. With pancreatic, only 12 patients, but the response rate, again, is 42% going up. So this drug binds a little bit better than ADA and Soto. So this is kind of the next coming, as you can see, like just like this is, it's just following the story like other small molecules, other inhibitors in patients with like lung cancer, especially EGFR binding. So again, better, like you've seen the waterfall plots, right? I showed the Soto, I showed you the ADA, I've shown you now, this is in patients with the Lilly drug. Next slide. This is Devising. This is the Genentech drug, GDC 6036. They published this at NEJM. As you can see, they didn't have, they had the basket again, pancreatic cancer. 7 patients with pancreatic cancer, number small, response rate remains the same, about 42%, very similar to the drug, which is very similar to the drug from Lilly, but small numbers again. Next slide. And this was another inhibitor, the Glycyrasib, I can't say it properly, presented in ASCO GI this year. So now I've showed you Sotorasib, Adagrasib, the Lilly drug, I've forgotten what it's called, Devising, and Glycyrasib. So let's look at the amount of drug development that you've seen, the 5 drugs back to back coming out fast. Next slide. And this was essentially, mostly this trial was done in China. So this was, again, this is all in PDAC. Now, this is a higher number of patients, right? So if you really look at these patients, who are 31 patients, similar to the ADA data, we had 21 patients in ADA, 28 and in SOTO, and then we had, again, 7 patients, 11, 12 patients in the other. But this is a proper PDAC cohort. This is a proper PDAC cohort. Again, see the waterfall plot? Looks very similar to the Lilly and to the Genentech drug that I've shown you. So this is Glycyrasib. And this, if you can see it, the overall response rate for PDAC was 42%, and the disease control rate, stable disease plus, response rate was 93%. So look at the data cutoff. You don't see this with PDAC. If you had told me about 4 years back that with PDAC, that we can show with a pill, I can give you a pill and I can show these response rate, I would not believe you, though I've seen a lot of PDAC, because, there was all the talk about tumor microenvironment. It's very hard. There's a shield. You can't crack that with pancreatic cancer. But really, if you have a target, if you have a great target, you can actually do it. So it's so it was very heartening to see these results. So you can see these higher response rates with the C drugs. Next slide. This is a progression-free survival and overall survival. Again, the overall survival of this patient was 10.7 months. Again, these are pancreatic cancer patients pre-treated. And I'm coming to the end of my talk, but next slide. So, but where are the, G12C is a small portion. We have the G12D, VRs. Remember, we used to have the DVRs in India before digital video recorders. That's why I remember it. That's how I got through Maulana's art, trying to remember all these little short forms of our drugs, right? Pharmacology, particularly was challenging. But anyways, that's the DVR, if you want to remember. Those are 3 major alleles in pancreatic cancer. D is 40%, B is about 15%. Again, B is about 20%, R is about 15%. Next slide. So this is the beyond KRAS G12C. So all these inhibitors are coming. So, and if you look at the KRAS G12C, look at on the left. I can't even count. These are more than 10. G12D, all these inhibitors are coming. This is RMC, this is Revolution Medicine, which is really leading the field. This was a company founded by Shaukat that I showed you, who first showed that we could target KRAS. So all this data is coming by this small company called Revolution Medicine, which is really making these pan-RAS inhibitors and G12D inhibitors, and they have G12V inhibitors in the pipeline. So a lot of interesting stuff that's going to be coming out. So you're going to see every conference now, ASCO, ACR, ASCO GI. You'll see more and more and more data come out every time with some kind. ACR, one of my colleagues, Scott Kopetz, he presented the Adagrasib with cetuximab G12C data in colorectal cancer. So all that data is constantly coming out. Next slide. And we've come to the end of this. So, but if you want to hear more about the Ds as a teaser, so this is, I don't know if Vikas Ostwal from Tata's is on the call, but Vikas, thank you for inviting me to come to Calcutta. I haven't been there since I was a kid. So I'm super excited about that. This is in June 8th and 9th. So if you guys are coming, would love to meet up with you, talk to you more about RAS. I could go for hours and hours talking about this topic. But I want to give a more in-depth, detailed look at, the now that you've shown with the Cs, but I'm going to